Well, good afternoon. Thanks for joining us. My name is Patrick Hall. I'm with CancerBridge, and we'll be introducing Dr. Flynn to give our Cancer 101 presentation. Again, thanks for joining us, and we just wanted to spend a few minutes giving you an overview of the CancerBridge service, and then we'll hand it over to Dr. Flynn. So CancerBridge is a cancer-focused navigation service that provides you with immediate one-on-one personalized access to a physician like Dr. Flynn, and who is an expert in your specific type of cancer. So we provide immediate expert guidance at a time of uncertainty. So the CancerBridge service is for both you and your family, and you receive someone knowledgeable who will listen, and you'll get rapid access to an expert physician in your specific cancer, and you'll also gain an understanding about your specific cancer. We'll also provide guidance on next steps and avoiding mistakes through the navigation service, and again, we'll provide you immediate answers in a time of crisis. I'd like to introduce Dr. Flynn.
Thank you, Patrick. Good afternoon, everyone. Wait for the slides to be switched over here. There we go. So today I have the pleasure of talking to you about really the basics of cancer. I think everyone knows somebody who has cancer, and we're often left with the questions as to really what's going on. What I want to do today is give a real good overview of cancer and demystify some of the areas and really leave you with some ideas of where we're headed in oncology. We'll start off with an overview, talk about some statistics to give you a sense of where do we see cancer, what age groups, what populations, talk how do we diagnose, how do we treat, and really touch on the different main categories and then the new directions. So cancer's really changed from when I first trained. This slide really talks about a number of different things we look at, immunophenotyping, mutation detection, looking at all kinds of different markers in the tumor cells. It's become very complicated. So it's changed from just being where we look at it from where it's located, so breast cancer, lung cancer, colon cancer, to being more of not only where it's located, but what are some of these really specific mutational determinations and markers within the cells. Highly complicated arena of care now. It's growing. Cancer as an entity and how it's impacting society is growing. It's becoming the #1 cause of overall death in the age groups 40 to 79, which is really our primary working population of folks. There's 13.7 million survivors. It's soon to grow to 18 million survivors. So that means that virtually every company, every family will have somebody that they'll know that is a survivor, and you'll be dealing with the long-term sequelae, and how do you best approach those patients to make sure that they're doing as well as possible. 1 in 2 men will develop cancer, and 1 in 3 women. And it's highly costly to our society, both in terms of the financial cost of care, but also lost wages, work impact, etc. So what is cancer? And this is kind of a funny slide, but cancer is really just you have a funny-looking cell. So normal cells look odd. And it can be that, or it can be just that they have abnormal growth, so they're growing uncontrolled. Most of our cells in our body have what we call apoptosis. They'll have programmed cell death, meaning they have a normal lifespan. And when that gets turned off, you get abnormal growth, so that can make a tumor. I alluded to the cancer incidence, but as you can see here that we've done a good job in the last 30 years, to really 25 years in dealing with cancer. 1972 is when we declared the war on cancer, and we started seeing the impact in 1991, where we started to see the decline in mortality. This blip here is when HIV started, and this is the peak here is when we actually developed heart therapy, so to actually be able to treat their HIV disease. Looking at most common diseases, so prostate, lung, colon, and bladder in men, and breast, lung, colon, and uterine in females. Cause of death, lung cancer, most common cause of cancer death in both males and females. It's important that we understand that depending on age will really determine the likely subtype of cancer that we get. So if we look at the adolescent young adult, which is really age 15 to 39, there's specific tumor types that we can see. And as we get older, there's differing subtypes. And that includes the biology of the tumors. So this is graphics of the difference between younger patients with breast cancer and people, I'm not going to say older, but people over age 50, and that there's a difference in the biology of the tumor, and also there's a difference in how patients do. Having an understanding about that will help us in how we approach patients with their specific subtypes of cancer. So this is a heartwarming slide for me. If you look from the 1990s is when the first time we saw actually a flattening of mortality. Had we not had the improvements due to science, we would be experiencing multiple millions more patients that would have died of their disease. So really we've had a profound impact on cancer mortality due to the discoveries that I pointed out in the first slide. I talked about the most common cause of death in men and women in cancer is lung cancer, but as you can see here, depending on their age, will determine the subtype of cancer that they have that results in death. And for females in the population 20 to 59, breast cancer is the most common cause of cancer-related death. So how do we screen for cancer? Well, the first thing is we do it ourselves. We breast self-exam, looking for skin lesions, things of that nature. Certainly if you have symptoms, that's a way that we screen. So somebody comes in, they say, boy, I have this symptom, and it helps lead us to look for the diagnosis. Certainly if increased lymph nodes, it's another way. We're all familiar with mammograms. This is an example of mammogram, and it gives you an example of the importance of really this program so that the proper patients getting the proper screening, the proper treatment, the proper diagnoses. We can see here in a younger person that if you had a mass that would show up as white in here, you wouldn't see it. So it would really be a wasted study, and there's other means that you can actually make the diagnosis as compared to an older woman. Ultrasound is another modality. You can see somebody, very common to have fibrocystic disease in the breast, and having that understanding is important. There's a population now where we know that there's a genetic proclivity for developing breast cancer, so where does the proper utilization of MRI come into play? And that's really important that subspecialists are involved so they can actually guide on that. Colon cancer screening, that's one disease that we can actually really alter the outcome of patients with this disease. So getting your colonoscopy after age 50, if you find polyps and they're removed, you develop the same risk as somebody that has no risk at all for colon cancer. So you can actually prevent the development of colon cancer. Very important screening modality. So diagnoses. The easiest way that we find is with just taking a small needle and putting it into the tumor. So if somebody has a mass in the breast, a lymph node, in their neck, and skin lesion, you can actually put a needle in there, get cells, and make the diagnosis. This is an example of what doing a fine needle aspirate you can actually see and see that there actually is cancer here. You can look at the peripheral blood by just doing a regular blood test, and as you can see here, this beautiful purple cell is actually a cancer cell. So if I looked at this peripheral smear, I could tell that the person has what looks like could be a lymphoma. We can also do a core biopsy, which uses a higher gauge needle, a little thicker needle, gets more tissue. And that allows the pathologist to get a better visualization of the architecture of the tissue. And this helps us with our sensitivity and specificity to make the diagnosis. Bone marrow biopsies, where we put a needle into the hip bone to draw bone marrow out, where we can actually see things like leukemia. And these cells here are leukemia cells. And if I were to look at this bone marrow, I could tell you that this person has leukemia. There's other different tests now that we have available, whether it's immunohistochemistry, other molecular tests, but we can do those, which gives us more fingerprinting for those cells. So if you have cells that look very similar, that you can actually look at a molecular level and make a diagnosis. Very important to have that capability. Imaging, so radiographs. This person here had a tumor eat through her arm. This person has a tumor in the spine. So somebody comes in with back pain, getting an x-ray, you'd see this, and you'd say, well, that's a problem. That will help us towards the diagnosis. CAT scans, I just want to orient you. This is the right side, this is the left. We're actually looking up the torso, looking towards their head, and that's right lung, left lung. And we can actually use this to make determinations if there's a mass present and try to help us with our diagnostic modalities. PET scan just takes a sugar and puts a radioactive isotope to the sugar, And tissue that's more active metabolically will concentrate the sugar, thus concentrating the radioactive isotope, making these darker spots. We also have what we call PET CT fusion, which does the same thing. And as you can see here, these yellow lighted areas concentrate the radioactive isotope, making it brighter. And I can correlate that with a CT scan to see if there's actually a mass there, or is there just a pooling of blood, or there's some other cause. So now let's talk about the therapeutic approaches. So classically, we think of with solid tumors, and when I say solid tumors, I'm talking about breast cancer, colon cancer, lung cancer, those types of diseases. Surgery is the key. And that's why when we talk about finding and diagnosing early, the less surgery needs to be done, the better. So if you can actually surgically remove the tumor, that's your best chance for cure. And as you go further, radiation is important, chemotherapy, then combinations, and now biological therapies. And I use the biological therapies as a wide category, everything from molecularly targeted therapies to other antibodies. And these all go into the play in treating these diseases. We've made profound strides forward. If you look at melanoma, renal cell carcinoma, breast cancer, et cetera, we have targeted molecules that can actually specifically go after little parts in the tumor cells, causing the cells to die. Blood cancers, so we're talking about leukemias, lymphoma, multiple myeloma, it's a little different. Surgery has very little role, radiation slightly more, but really it's chemotherapy and the biological agents. So surgery is, we basically just take the tumor out. You try to get wide margins so that you're sure you get all the tumor as best you can. And then a patient would have surveillance, making sure that it doesn't, quote unquote, come back. Now, it's really not coming back. It's really that there's cells left behind and it continues to grow, but that's the goal. You've heard of mastectomies, and our surgical techniques have changed over the years. So years and years ago, there was radical mastectomy. They were very invasive procedures with a lot of toxicity from the surgery. Then they went forward with a modified radical mastectomy, which saves some of the lymph nodes so they don't have swelling and a lot of the untoward effects of the surgery. And then breast-conserving therapy, where they actually go in, take out the mass itself, and then radiate the tissue around that. And it's comparable outcomes to more aggressive therapy. These have all occurred over the last 3-4 decades. Radiation, most of us think of radiation in the negative light, but it actually has a very important role in cancer therapy. Now this is, if you can think of this as a CT scan that I talked about, the CAT scan, this is the right lung, left lung. We're looking up towards the head. And if this is a tumor, what happens is these coils go around the body and shoot radiation through. So what ends up happening is the radiation kind of coalesces in the tumor and crosses here, giving most of its energy in the tumor, causing the cells to be killed. And then the systemic therapies. This is where I toil and I spend my time. And it's really, if you think about the onset of systemic therapies, the SS John Harvey really is the start. And that was a ship that was bombed in an Italian harbor in World War II. And the sailors jumped overboard and found they were losing their hair, they were getting infected, and their bone marrow was wiped out. And they found out that there was nitrogen mustard gas in the hold. And that ended up being what they decided. They injected a similar compound to somebody with lymphoma, and it actually treated their lymphoma. So you can think about that as being a toxic, a chemical warfare agent to fight cancer. And that's where really it started in the 40s. We've made great strides forward in that time. And really the focus of all the chemotherapy was to impact the cell and cell cycle. So I'm sure you can dig back to your high school days where you talked about this, but where your cell is in different stages in the cycle, the chemotherapy targets these areas, specifically impacting that. And it really kills all cells that are dividing. And the cells have to be dividing for the chemotherapy to have its real effect. But it's really, if you think about it, it's like taking an anthill and actually blowing the heck out of it as opposed to just killing the ants individually. And that's really where chemotherapy. And that's why, if you think about it, there's patients you may have known that have had the hair loss, nausea, vomiting, fatigue, and other impact because it was a very, very non-discriminate way of killing the cells. And with that, our biggest risk with that was infection. So you may know people that have ended up being hospitalized and getting infection. And some patients die of infection. So really, sometimes the treatment was ultimately the resulting cause of death. With these therapies, you may know people that have had a central access. And we do this to allow us to get the chemotherapy into the big blood vessels so that they can, one, not cause burning or toxicity, but also mixing and gets diluted with greater volume of blood. And you put the port here, we inject right into the port, and the chemo goes in, and it gets absorbed systemically. Let's talk about our growth of understanding in the last few minutes. Watson and Crick. I don't want to make anyone get apoplectic about thinking back to, again, high school genetics, but that was really the first foray into understanding about the genetics of cancer. Looking at other discoveries after that, Philadelphia chromosome lets us know that there's specific mutations that happen in these tumor cells, and all cancer is genetic, and I'm not talking necessarily mom-dad genetics, we're talking genetic changes in the cells, resulting in the changing of those cells to either be, again, funny-looking or growing abnormally. We also know that on the surface of many of these cells, there's specific proteins that we can now test for that actually will show up on something called flow cytometry. And depending on the subtype of cells, the white blood cells, we can determine what type of leukemia or lymphoma it is, and it depends on some of these surface markers that we see. And me as a hematologic malignancy physician can look at that and say, oh, this is the subtype of lymphoma. Back in the early 90s, we wouldn't know that. We'd have to basically say it's one of these 4 types of lymphoma, and we would treat it accordingly. Now that we're much more specific, we can treat it more specifically. And as a result, we've developed many antibodies that go out and specifically bind to those surface proteins causing the cells to die. So these are examples of a number of antibodies that have been designed specifically to target cancer cells and in the timeline for which they've been developed. Which takes us to the modern age. These are all different targets within the cells. If you can imagine this big group of cells being like the engine of a car, and in the old days, if you wanted to shut off the engine or destroy the engine, you'd have to throw a hand grenade in the engine compartment. It would explode, you'd stop the engine, but you'd probably damage the car as well. Now we can go in and actually target specific things like the PI3 kinase, etc., causing the cells to die. That'd be like you going in and cutting off the fan belt or cutting the fuel line or cutting the battery cable. Much, much different. And we can do this for many, many tumors that we have available now. Other cells that have been, or other drugs that have been developed looking at other pathways, whether it's apoptosis, angiogenesis, those allow us to actually take the tumor and use characteristics of the tumor against itself. And it's been the harbinger for change in cancer care. So I'll just finish up on bone marrow transplant. This is an arena where there's 2 types, autologous and allogeneic. We do use this treatment for leukemia, lymphoma, multiple myeloma predominantly. There's other areas you can use it in: solid tumor, testicular cancer, ovarian cancer. And you're basically either getting your own cells back after you get high doses of chemotherapy, or you're getting somebody else's cells. And basically, we harvest the cells, and the person gets chemotherapy, then they get the cells put back in the system, they find their way to the bone marrow, take root, and make normal blood cells. And I will part on this, some really exciting things, cellular therapy, looking at taking a virus, infecting people with a virus, which changes your own blood cells to target a specific protein against the tumor. So then you're basically having your T lymphocytes targeting cancer cells for the rest of your life. And that we're doing here and in a number of other places in the country. So we will end on research, because I think this is what's the gas that's driven this. This is what most people think of research, people sitting in a lab, and that's an important part of it, but it's much, much more than that. We have that part where you're developing these agents, then phase 1 where you're trying to figure out what is the right dose, phase 2 trials where you're looking at how effective they are, phase 3 where you're comparing it with a standard, and phase 4 which is aftermarket. Phase 1 has really changed now with the targeted therapies, because we're so good at actually knowing the biology of these agents that we can actually have a good determination before we even bring people into a trial whether or not it's going to have some at least binding activity. And that's really changed how we look at cancer care. Now understand that one of the questions we're often given for research is, will I get placebo? And generally speaking, the studies don't include placebo. It's not usually the agent versus placebo in a study. It's usually the agent, and you're seeing how active it is. So it's an important differentiation from some of the other diseases where you may be randomized to a placebo arm. So I'm going to stop there. That was a really shotgun, quick approach at Cancer 101, but hopefully gave you insights And we'll stop now and actually see if there's any questions from the audience, both locally or remotely.
Thanks, Dr. Flynn. One of the questions that came through is, are all cancers hereditary?
So the question is, are all cancers hereditary? And as I alluded to, all cancers are genetic but not hereditary. Now we know that in breast cancer, and most people are surprised to know that only 5% of breast cancers are hereditary, meaning got passed down from mother or father. We're starting to see that in an array of cancers, chronic leukemias and otherwise, that there's some genetic predisposition, but probably around 5 to 10% of the patients who get cancer will be hereditary.
Can cancers be prevented?
Great question. Probably the most important thing we can think of. Can cancer be prevented? And the answer is many of them, yes, they can. Now, many of them can't be. So colorectal cancers can be prevented from early screening, early detection. Skin cancer, which is the most common cancer, if you look at squamous cell carcinoma worldwide, and that's the key is to use sunblock, sun protection, wide brim hat, stay out of the sun. Sun damage is a key component to that. So there are certain things that can be done to prevent cancer. There's other things you can't prevent cancer. Certainly, breast cancer is not really preventable. There's an array of cancers you can't prevent. But in general, as we're learning more and more, we know that being the proper weight, being active, all can help prevent cancer and impact on the society as a whole.
Thank you. Are there any examples of good cancers?
The question is, are there any examples of good cancers? And so I have a little bit of a jaded approach. There's oftentimes people come to me and say, oh, I was told I have the good cancer. And well, there's really no such thing as a good cancer. There's good outcomes, and there's some cancers that actually have a much better outcome than others. So for instance, if you have squamous cell carcinoma of the skin, localized, they shave it off and you're done with that. And the spectrum is broad from those that have that kind of outcome to those where untreated there could be 6-week survival. So I would say there's no good cancer, there's just some that have better outcomes than others.
One of the questions we got is, what are the survival rates? I know it's probably pretty variable, but if you could speak to that.
Sure. So the question is, what are survival rates? And it certainly is variable. I gave a graph that showed, in general, that we're doing much better with survival. Every year, I can tell you that with the discovery of new and novel therapies, that survival is improving across the board. As I showed the graph that was just a year old, mortality from all cancers combined is decreasing, which is really fabulous. And we have many, many examples here of patients that 15, 20 years ago would not be alive today, but now they have a lot of opportunities that they didn't have before. So it's a really hopeful time in the both treatment and discovery world of cancer care. I think that for individuals afflicted with cancer, those with family members, there's a lot of hope out there. There's discoveries every single day. So what you're told today may be something different in 2-3 months because we're making discoveries that rapidly. So it was a broad question, but I think that I will just suffice to say that survival is improving markedly with our new discoveries.
What foods can help fight cancer?
So the question is, what foods can help fight cancer? And that's been studied in great depth. It's a very difficult thing to study, and I'll give an example. Back probably 1995, 96, there was a study that came out that beta-carotenes, patients that had diets high in beta-carotene may have decreased lung cancer. They thought vegetarians would have decreased cancer. And when they studied it in a randomized fashion, the population that had beta-carotenes did worse. And the thing that we realized was it's probably more complicated. That if you eat a carrot, for instance, you're getting more than just beta-carotenes. You probably have a different lifestyle. You may have decreased incidence of smoking, etc. So there's a lot that goes into that. I say as far as foods you can eat to decrease risk of cancer, there's more and more data showing that if you are not obese and that you're active, that your risk of cancer goes down. And we know that, especially colorectal cancers, if you look at Asians that are actually living in Asia, have a very low incidence of colorectal cancer. When they come over to the United States, second-generation population actually approaches that of the normal American population, really leading towards the idea that it's diet-related. So low-fatty foods, high vegetable and fruit content will impact on cancer in a general sense, but healthy living is the most important.
We had a listener whose both parents died from pancreatic cancer.
So somebody with both parents having pancreatic cancer, and what's the propensity for having pancreatic cancer that's a very difficult question to answer. A lot goes into what ages, what exposures, et cetera. We don't really know fully what the predisposing causes of pancreatic cancer are. It's rare enough that it's very difficult to make a clear genetic association with that as well. Most patients, the reason it's difficult to treat because most patients don't know when they have it that when it's discovered it's usually advanced. So the propensity is difficult to give this person.
One of the questions was, is cancer contagious?
So is cancer contagious? And the answer is no. I don't personally do anything special to, hug patients. I have family members who had cancer. It doesn't stop me from giving them a hug and kiss. It's not contagious. I think that the main issue that you worry about is if somebody's actively getting chemotherapy, that the risk of getting contagious infection to them would be the biggest risk, but not in and of itself that cancer is contagious.
What is remission? And you can talk through what that means for a survivor.
Sure. So the question is, what is remission? And that's actually changing in this day and age because of our new agents are so active and they have a different method as I described. So generally speaking, there's stable disease, and that's where the tumor stays the same. Then there's a partial remission where it's partially gone but still present. And then you have a complete remission. Complete remission is basically where you have no indication that there's any disease anywhere. And then if somebody's in complete remission for 5 years, we consider them cured. And that's in the solid tumor world. Now for patients that have blood cancers, it's a little different. That cure will be at 5 years for certain diseases. Some we know are incurable, although people can live a normal, long life with them, and it'll stay undetectable and may come back in various phases. But generally, if you're in complete remission for 5 years, you're considered cured. Completely alleviated, that's considered a complete remission.
This question kind of goes along with that. With the increase in cancer survivorship and more people living after having cancer, are there any special needs that they have? Special needs of survival?
Sure. So the question is, are there any special needs for all these increased survivors that we're seeing? And that's a phenomenal question. There's a whole new array of discipline called survivorship for patients that have suffered cancer and been treated and are cured. And survivorship really starts at the day of diagnosis, because I think as we're seeing is that because we're doing so much better, that we're able to deal with so many of the other issues that weren't really addressed in the past. And part of that was our focus was so much so on just how can we get people into remission that we didn't think of all the other effects, the psychosocial effects, the sexuality, fertility issues, things of that nature. And then the long-term effects. So patients that have had chemotherapy or radiation as a child for leukemia, Hodgkin's disease, things of that nature, have an increased risk of developing other malignancies. So, for instance, if somebody's had Hodgkin's when they were a child decades ago and they had radiation, their chance of thyroid cancer is 150+ fold increase over the normal population. So having proper screening as you go forward, if you've had young women that have had radiation under age 21 to the chest, that the incidence of breast cancer goes up significantly. So we do look at the whole array of treatments they've had, what type of disease they had underlying, and then we can look at things like their blood counts, make sure they don't develop other impacts from the treatments itself. But the arena of survivorship is very, very important, and it deals with everything from financial counseling to symptom management and long-term effects of therapy.
Are there any vaccinations that reduce cancer risk?
So are there any vaccinations that reduce cancer risk? And the answer is yes, there is. The HPV vaccination is something that all of our young children should be getting. The HPV is associated with both head and neck cancers, also cervical cancer and other infectious cancers. So getting the HPV vaccine is vital. There's other vaccines that are probably going to be coming along which will be impacting on that as well. But certainly the HPV vaccine has had a profound impact on cancer rates.
That's all the questions that we have.
Any other questions if you're here? Well, thank you everyone for your time. Hopefully it was informative to you, and please reach out to this email address if other questions arise. Thank you.